Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring you another episode of the AOMT podcast. Today, our guest is Dr. Dan Rhon. He is a clinician, researcher, and assistant professor at Baylor University in Texas. He earned an entry-level degree and Doctor of Science from Baylor University, a DPT from Temple University, and he is currently working towards a PhD. He is a fellow of the American Academy of Orthopedic Manual Physical Therapists, and Dr. Rhon also completed a postdoctoral research fellowship through the University of Utah. He is the research director for the postgraduate physical therapy program at Bellin College in Green Bay, Wisconsin, and he is currently the vice president of our academy. We could say a lot more about Dr. Rhon and all of his accomplishments, but let's go right to the source. Dr. Rhon, welcome to the podcast.
Hey, thank you, Steve. Thanks for having me, and thanks for not saying a lot more about me. That's good.
So let's get down to the topic at hand here. We invited you to the podcast because of a study that you were the primary author on. The title of the study is The Influence of a Guideline-Concordant Stepped Care Approach on Downstream Health Care Utilization in Patients with Spine and Shoulder Pain. And to get things started, I would like to ask you why you performed this study.
Yeah, that's a good question. This is maybe a little bit less of a, direct to the clinical or clinician type of study, and maybe something that's a little bit more relevant to policy. But real quick, if you don't mind, I just want to set the background, the foundation. It'll kind of help understand the study just by reviewing what stepped care is, in case some of our listeners aren't familiar with it. But stepped care is just sort of this idea that you sort of transition from lower steps of care that are maybe less risky up to higher steps of care as needed. So, not an example would be not everybody needs spine surgery for back pain. I don't think anybody would argue that. And so if everybody that came in and we jumped up to the highest step on the ladder right away, that it wouldn't be a wise use of resources and costs, and it's probably not very safe and the best thing for the patient, considering a lot of patients, or the majority, would get better. So maybe step care for back pain might be something like even self-management. Here's some websites, or maybe you have some flyers in your clinic at the primary care level, and then maybe the next step, they don't get better. Maybe some pharmacological management, maybe a referral to PT, something, exercise. And if they're still not better after that, then maybe another referral to another specialist. And so the idea is that care can be more efficient, safer for the patient, and a better use of resources. So you're not handing out care that isn't really necessary until you get up to these higher steps. And so that's sort of the idea behind stepped care. And so this study, really, we just wanted to look at this at a hospital level, all the patients coming in with spine and shoulder pain, and see, the best way we could describe this is we thought, we know opioids are not considered initial stepped care. I mean, we don't advocate for patients getting opioids as sort of the first intervention. And we know that manual therapy, which most of us in our organization at least are familiar with, obviously, is something that's advocated as sort of an initial care, spinal manipulation or manual therapy for managing pain. And so it just presented this opportunity to look at these care models and say, let's look at everyone that received manual therapy and then see how many of those also received opioids, and whether they received opioids for their spinal pain before or after the manual therapy. And then, because it's hard to identify outcomes self-reported outcomes. We just wanted to look at their overall cost of care in the year following that initial episode. What would the cost be look like, the visit? So what were the healthcare and downstream healthcare resources based on whether you received a more appropriate early intervention or perhaps a inappropriate intervention before a more appropriate one, if that makes sense. So that was sort of the idea and the gist behind the study.
That is a great introduction and also a great view into the background and the importance of the study. So thank you for giving that to our listeners. There's actually a lot of things we could pull out from what you just said, but one thing I want to focus on in particular is the fact that you mentioned manual therapy, and I find it very fascinating and very important that in this study, you're not just looking at OMPT, orthopedic manual physical therapy, but you also included other professionals such as chiropractors and physicians. Can you talk about that? Can you talk about the importance of manual therapy just as a general intervention and why, perhaps when you designed the study or when you looked at the data or just whatever flair you want to give it, why was it important to include not just physical therapists, but other practitioners as well?
Yeah, that's a great question. I think probably several different reasons for that. But, for one thing is we are looking at a health system. And so if we know that manual therapy, at least in the guidelines, it doesn't necessarily say manual therapy that has to be delivered by a physical therapist or was delivered by a physical therapist. And so, to try to remove your biases from this, obviously as a physical therapist, my first inclination is let's look at PTs delivering this. But, we happen to have chiropractic care, and we know that we have osteopathic physicians that also, use manual therapy. And so really to get a better idea of who's getting guideline adherent care, it seemed more appropriate to include everybody that's delivering this treatment and not just the physical therapist. And so that seemed to be a more appropriate way and maybe a little bit more unbiased way to sort of address the question.
That's excellent. And I really like the fact that you're trying to be aware of your biases and then, working around them so that you can try to get as solid of information as possible. That's something I, of course, try to do in the clinic as well. I tell my students all the time, if you're not aware of your biases and you're not trying to account for them, then you're doing something wrong.
Yeah, that's a great point.
My next question is related to, again, the background and the overall concept. And this has the potential to be a rabbit hole, of course, but I'd like to get your opinion real quick on how the healthcare system is impacted by the fact, for example, that some of us have more musculoskeletal training, knowledge, and experience, and other providers have more medical training, etc. Could you discuss how that factored into this overall situation and how we should view that perhaps from a clinical and research viewpoint?
Yeah, that's a good question. It's a little bit of a rabbit hole, but I don't know if I can directly connect those two because this was observational data and it was data taken from our EMRs. And so it's really hard to, know everybody's situation and exactly what's going on. And so sometimes these studies help sort of see the bigger picture and then, help set up hypotheses for additional studies, or let's look at components and see if it pans out in a prospective study. It doesn't always do that, but it sort of gives us ideas and says, here's something that we should look at a little bit more. How can we figure that out? And I don't think it's any surprise that I think there's two sides to this. It's a bit of a double-edged sword. I don't think it's a surprise that the expertise, education, and training in musculoskeletal medicine, is different between primary care providers, let's say, and physical therapists. I think that's been well documented. There's lots of, resources showing that, doctors, even just GPs in particular, maybe get less than 8 hours of musculoskeletal medicine total in their curriculums. There's also lots of PAs and nurse practitioners that work there that, I've gone down and given lectures to in those settings. And, it's clear that's not their sort of expertise, and we wouldn't expect it to be, right? I mean, we spend 3 years just becoming experts in a musculoskeletal focus, and then we have a residency and a fellowship, whereas they have to address a whole host of other things. And so I don't think that's surprising. It's not really, look at us versus them. It's just that happens to be our specialty. But the flip side of it is, I don't think everybody needs to go to physical therapy right away. Like, we're not the initial step. And so the reality is that sometimes in the clinic, especially in primary care, there's a whole host of things to consider before sending someone to see a physical therapist. Part of that is, payment models that can vary, although that isn't as big of a problem in our setting, but also just time. Not everyone is able to get away from work. Maybe you're a homemaker and, you've got kids and you're like, man, I don't know what I'm going to do with the kids. And I got to come in 2 or 3 times a week. So there's all these other practical considerations. And so sometimes, here's some meds or here's some opioids. Unfortunately, might just be easier. And so there's a lot of practical issues to consider. I wish it was a little bit more black and white. I will say that what I did find that was interesting, and this maybe ties into your earlier question, was that there was a lot more treatments that included manipulative treatment therapy by chiropractors across the board. And then I think it was PTs and then the DOs. But what was interesting is that when it came specifically to shoulder conditions, when it was just shoulder conditions, it was almost all physical therapists. And when I looked into this a little bit more, I pulled up all of the clinical trials that utilize manual therapy for shoulder conditions. All the studies that we have for just directly for the shoulder, but also for the thoracic spine. I think it was over 21, something like that, RCTs. And I looked at who provided the intervention in the whole body of literature that we have to support manual therapy for any type of shoulder disorder. And every single RCT, the clinician that was delivering the treatment was a physical therapist. And so I thought that was really interesting. Maybe just in our literature, in our setting, that tends to be something that we go after. And maybe chiropractors and osteopaths just think of manual therapy for the spine and don't necessarily consider it for the shoulder. But I thought that was just a really interesting finding.
Yeah, I definitely agree on that. And just to go back for a moment to the question that I posed, part of my thought process, of course, is that we all have our niche. As you said, we're, as physical therapists, often considered musculoskeletal experts, which is, of course, in no way, shape, or form meant to state that the family practice physician or fill in any one of a number of different types of providers, that they do a bad job. It's just they have what they do well and we have what we do well. And it makes sense that patients, with shoulder pain, spine pain, et cetera, at some point should see the physical therapist. And, your study very nicely outlines why that's a good idea.
Right. And I think even specifically, we have several studies that show that physical therapy first leads to some, downstream improvements and decrease utilization, decrease high-risk procedures. And this is really probably one of the first studies that we have that, you could say manual therapy first, that really looks at manual therapy provided at least before opioids as an intervention and has very similar downstream outcomes: decreased cost, decreased amount of visits, a lot less healthcare resources. So I think it's something for us to consider, maybe in how you market your services. And I don't mean just financially, but, we all, even in a hospital and health system, we all want to, be part of the team and contribute, sort of market to the greater hospital. Hey, this is what we can provide. This is what we can contribute. And so if you consider us at least before some of these other higher risk interventions, there's a good chance that we can save you money and have better outcomes for your patients.
That is an excellent point. I like that a lot. And let's use that as a diving board to explore the results of your study a little bit further. Can you talk about the different groups in the study, what the difference was between them, maybe perhaps even how large of a difference there was between the groups, and what that really meant from a healthcare utilization standpoint?
Yeah. So, we broke the cohort first into those that only had manual therapy and then those that received manual therapy plus opioids. And so if you received manual therapy only, you had a lot less total outpatient visits. Your outpatient costs were about half of what they were if you received. This is downstream. So again, your downstream 1 year costs specifically related to spine and shoulder visits, spine and shoulder costs was about half of what it was for those that received opioids in addition to manual therapy. So that was really interesting. And then what we also did after that is we thought, let's look at what happens if you did get both. So if you got manual therapy and opioids, what happens if you received the manual therapy before the opioids or vice versa? So where in the sort of pathway did you receive this care? And so even with those, there was significantly lower costs. So if you had manual therapy before you had the opioids, you had a lot less costs and visits in the 1 year following that. So that was really interesting. And your overall opioids use was about half. So you had half the amount of opioid prescriptions filled if you had manual therapy versus before opioid therapy first. And then finally, we wanted to look at the timing of care. So we said, let's break the cohort down again into those that receive manual therapy within the first 30 days of their initial diagnosis compared to those that received it after 30 days. And again, there was almost all of our outcomes were significant. A lot less total opioid prescription fills, significantly less costs for all spine and shoulder conditions, total medical visits and costs. And so, but then we thought, because some people would say, well, as long as you get anything that you get first, is likely to improve outcomes. It's just the timing of care. So we thought, okay, well, let's look at opioids. What if you got opioids early versus delayed? So we looked at opioids less than 30 days versus opioids prescribed after 30 days. And that's where we didn't see a difference. In fact, sometimes the patients were worse when they received early opioids compared to getting them after 30 days. So their costs for all their spine care was higher. Their visits were a little bit higher. And so, that sort of rationale didn't really pan out there when it came to timing of care for opioids. But across the board, I think the bigger message was in this observational cohort that receiving manual therapy alone was better than getting manual therapy and opioids. If you receive both of those at some point for your care, getting the manual therapy before receiving the opioids was better. And then receiving the manual therapy within the first 30 days versus after the first 30 days was better.
That's obviously some really great information. Anybody even remotely dialed into the news cycle currently will know that we're having an opioid crisis. And, if a study like this, for example, demonstrates that we can use less invasive, less risky interventions to help, decrease costs and, let's be honest, make patients better, then that's a great thing. And I'm obviously fully on board with that. Speaking of which, can you go back and talk a little bit more about the overall difference between the groups? You used at one point a phrase, I think it was a lot, and you talked about the percentage of opioid prescriptions. I think you said 50% less. What else was there in terms of the cost difference? How much money are we talking about? Or are we able potentially to save 10%, 20%, 50%? How big is the difference between the groups?
If you had manual therapy only versus manual therapy and opioids, the cost related to spine and shoulder disorders was about $3,200 for manual therapy and opioids. And this is your full 1 year cost. So all of the costs in the 1 year following related to spine and shoulder visits versus about 1,700. And the standard deviations are pretty tight there, but 1,700 versus about 3,200. So almost twice as many costs specifically related to spine and shoulder costs. When you look at all outpatient visits and costs, the costs were about 10,500 versus about 5,400. So almost double the total cost. And then when you looked at whether you had manual therapy first or opioids first, it was about $12,000 in overall costs and about $10,700. But that was for all costs. And when you looked at the spine and shoulder conditions, it was about $3,800 versus $2,800. So about $1,000 more for shoulder and spine care if you had opioids before you had the manual therapy. When we looked at if you receive manual therapy within the first 30 days versus after the first 30 days, we're looking at about $1,700 for before 30 days and about $3,200. So difference of almost $1,500 just by getting the manual therapy early versus delayed. And so just across the board, the amount of individuals that had prescription fills was a lot less, so about 16% less that received an opioid prescription if they received manual therapy within the first 30 days compared to after the first 30 days. So those are some pretty substantial savings, I think, in healthcare system across the board. For one patient, that adds up.
I obviously agree on that. And, if you're quoting numbers that are for this patient or that patient, or you're looking at averages overall, it's pretty difficult not to also think of, the entire system, or let's be honest, if we can impact the entire country, we're looking at the potential for a lot of savings. And just to pull out one of those numbers, if you asked anybody, would you like to save 50% on this car, this house, this whatever, I don't know anybody who's not interested in saving 20%, 30%, 50%. So, these are impactful numbers. Part of what it tells me is that if we approach the healthcare system from a certain, vantage point or structure, et cetera, then we can have a real big impact on what the overall expenditure is going to be. And, that would be great for not just the armed services, obviously that's the area in which your study was conducted, but also hospital systems, states, the country as a whole.
Yes, absolutely. I agree. I mean, half of the visits, if patients only have to come in for half the visits. And I just want to make one quick note too. So it is the military health system. It is a single payer health system. So that's probably what differentiates it more from sort of this, the U.S. is primarily a insurance-based third-party payer system. However, most of our patients were not military service members. A little less than half were, I think. And that's, we see family members, spouses, children. We also have all the military retirees. So once you, and they're not always, that old. I mean, you can retire after 20 years. So 38, 39, and then you get medical care. So it could be a little bit younger, but not everybody is in the military. So I think there's a little bit of probably translation from there into maybe other settings, although it is a little bit different.
That's an excellent point and an excellent clarification. And it makes me think of the data that's come out of Alberta, Canada with Linda Woodhouse. They've looked also at a similar approach, send to a physical therapist before a surgeon, for example, joint pain, so on and so forth, back pain. And they've had very similar good results. So, I think it's appropriate for you, of course, to discuss the limitations of your study and how it might apply to the general population. If we look at examples like those created by Linda Woodhouse and other individuals, I think the ongoing theme is relatively clear, and that is physical therapy as a first step intervention is often the type of variable that can help systems as a whole bring costs down.
I think we need to be a little bit careful with that because I think the data that we have shows that PT utilization is maybe around 15% for everybody that comes in with back pain. And so I know in our clinics, we're pretty busy. I don't know if we could handle the additional 85%, but I just don't think everybody needs that. And so I think just to keep this balance, I definitely think physical therapy needs to be a very strong component of this sort of management plan. But we also need to get better at determining who is going to be just fine and who's going to excel appropriately from self-management. And so, we need to be in that process earlier before some of these other interventions, but we still need to figure out, who is it that's going to be fine on their own, and how do we identify those people, and then who do we need to send to physical therapy right away and early because they're going to have better outcomes. And I think that's kind of the secret sauce that maybe a lot of us are looking for.
I agree 100% on that. It actually reminds me of one of my favorite mantras, and that is, if the patient has a mechanical problem, we want a mechanical solution. If they have a chemical problem, we want a chemical solution. And obviously it's more complicated than that. But I think we can and should expect that any provider, a family physician, an orthopedic physician, a chiropractor, an osteopath, an OBGYN, a physical therapist, that they can all perform an eval and say, okay, based on my professional opinion, I think this person needs to go here or there. I am qualified. I am not qualified to see them. And, just thinking back to last Thursday, I had a perfect example of this where I've been working with this lady. She's getting better. She has back pain that goes down her leg. And she missed her previous session. She called me up and she's like, oh, Steve, I really need to get in to see you. My pain is horrible. And she came in, and to be honest, she looked really uncomfortable. Something had really seriously changed. And, I sat her down, we had a conversation, and it became pretty obvious. I won't tell you the whole story because we don't need to go there, but, I don't know what was wrong with her. I haven't followed up with her yet, but it was clearly something, maybe a bladder infection, a kidney infection. It was definitely medical. Her back pain was no longer the same back pain, and she very clearly described it as, no, this is not the problem that you've been treating. There was this other symptom. She could no longer urinate. She didn't have a temperature, which was good. But it was something that we had to get out of my clinic. And, I guess this is all in part a way of saying that I agree with you. Not every patient needs PT, and this is just one example of that. We need to figure out who needs us and who needs someone else and try to move forward as effectively and efficiently as possible.
Yeah, no, that's a great example. Part of that is going to the PT and then having a competent physical therapist that is able to identify that and say, okay, this is something that is medical, and let's get you to the right individual that can manage this. Just like someone in primary care might say, this is mechanical or, pain related. And I think let's get you to the right person, maybe a physical therapist.
And this, of course, is a biased question. This is the AMPT podcast, and I'm obviously a fellow, and you work as the VP very close with us. But what would you say to a physical therapist that is considering going to get extra training? And let's even open that up to a broader topic, especially somebody with your training who has so much experience in the academic world. What's the value of residency training, fellowship training, academic doctoral training, and why should people consider that?
So you mean beyond your entry-level training?
Yes, sir. That's exactly what I mean.
As most people would argue, you come out as in most professions, right when you graduate, that's really you're sort of at the very, very base. You can pass your licensure, you have very little relative experience, and our lifelong goal really should be, how can I get better at my trade? How can I improve in my trade so I can improve my outcomes? I don't even think that's just in medicine. I think that's in most trades and professions. You're looking at being a master craftsman at whatever you do. And so that's very similar here. And so PT school is a bit broad in that you have to sort of learn a little bit of the basics of a lot of different specialties, and then when you get out, you're going to go in and practice most likely in a much smaller niche. And so if you want to be better at your craft and you want to become more competent, definitely experience is one thing, but you really can fast track being in residencies, fellowships just provide an incredible amount of structured mentorship, structured guidance, structured learning that really push you in a direction of mastering your trade, if you will. And I just think it's it's just really important. It's a sign of, hey, I want to be better at what I'm doing. It shows others that this, I wanted to do more, and so I want to reach this other level of competency. I care enough to want to go after this. I care enough to want to be better. So I think there's a lot of different reasons. And really, I think from the bigger picture perspective, it's really necessary to keep our profession moving forward and being able to take these stances as, or just to take the stance as being, proficient and being an expert in this. The board certifications, the residencies, fellowship training really helps us fall in line with other medical professions that also want to specialize and become the experts in their fields.
That was very well said, and I obviously agree with all of that. As one final question, let me ask you, Dr. Rhon, do you have any future projects in the works that we can look forward to seeing?
I do have several projects. I'm just really interested. I think I'm probably a lot more in the research setting than in the clinic seeing patients, but I work in primary care. That's kind of where my lab, if you will, is. I'm just really interested in how things start at that very level, because again, if only up to 15% of patients get referred to PT, the types of things that I'm looking at sort of the population health level, it's really hard to answer those questions if we're only studying PT populations. That's a very, very small percentage. And so, we're just looking at how do we maximize our interventions at the primary care level when patients first come in. And so stratifying patients based on their risk for turning into chronic pain are some of the things we're looking at. Looking at, chronic pain management and integrating sort of holistic health. I've really gotten interested in just how the whole components of health sort of tie into a patient's prognosis. And when you look at research related to like sleep and pain, for example, and physical activity, not just the health benefits, but just how it affects a lot of other components, mental health, all of these things that we tend to silo in medicine, like that's your specialty, this is my specialty. But, when a patient comes in to see us, all of these things they're all encroaching on that patient's life space, and they're all relevant, and they can all be relevant to pain and the disability that they're having. But we tend to just focus on, gait and range of motion, which all are important, but we don't always consider a lot of these other components. So I'm doing a lot of things with holistic health and health coaches, and how PTs can be better or do better at sort of addressing holistic health in some of these settings. And I'm really excited about some of those projects.
I like the sounds of that. And, to me, it sounds like the direction that you're taking with your research very nicely fits with the direction that I take with my clinical practice. So I'm excited to see some of those future results. Speaking of which, in terms of the future, if any of our listeners want to reach out and find you or ask questions, how is it that they can find you on the interwebs?
Well, you can always find me on Twitter. I'm, you always know when I'm at a conference, because I'm like a heavy Twitter user then, and then I tend to fall off when I'm not at conferences. But I tend to tweet out mostly, science and clinical type of things on Twitter. So you can find me there at Dan Rhon. And, you can find my email address on the AOMPT website under the executive board list there. It has all of us there, as I'm the VP, as you had mentioned. And so if anybody has any specific questions, they can feel free to, about this study or any of the research, they can feel free to look me up and send me an email there as well.
That's great. We really appreciate you being available for our listeners. And, with that, that's a great place to end this interview. I'd like to thank you for being on the podcast. And perhaps in the future, when you have some more studies that are published, we'll have you back.
Steve, thank you for inviting me, and just thank you for this wonderful podcast. You guys have been doing an excellent job with it, and I know this is just a valuable resource to the Academy. So thanks again for having me on.
You're very welcome, and thank you for your kind words.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.